Namaste students, today we will be discussing about one very important case for a postgraduate students. Okay, this will be kept for a postgraduate students. Undergraduate students usually they won't keep this case, but if they are interested they can go through the video, should not be a problem. But for a postgraduate level, this case from central nervous system will be kept in the exam. So this is a posterior circulation stroke, the case what I will be discussing today. Okay, a posterior circulation stroke will be kept for a postgraduate level, either the occipital lobe infarction or the lateral medullary syndrome. One of the classic case which they'll keep for the exam is the case is a lateral medullary syndrome or a midbrain syndrome or a thalamic syndrome. So any of these cases can be kept for a postgraduate student. So today we'll be discussing about a posterior circulation stroke. Already I have discussed the anterior circulation stroke hemiplegia, classic hemiplegia. 85-year-old male patient by name X. And his occupation is a farmer. He has education, he has studied till SSLC, that is till 10th standard, and he is from Bangalore rural, that is from a Kolar district. The chief complaint: numbness of the right side of the body since 1 week, giddiness since 1 month. So the chief complaint is numbness of the right side of the body since 1 week and giddiness since 1 month. History of presenting complaint: patient was apparently normal 1 week back, when he noticed one day that there is numbness of the right half of the body, including the face, hands and legs and shoulder. It was gradual onset and it progressed over 1 to 2 days, and then it is present since 1 week. History of giddiness: intermittent in nature, that is present since 1 month. Sudden onset, and he says there is giddiness while walking. The giddiness is not associated with headache, nausea or vomiting, and there is no tinnitus, there is no ringing sensation in the ear. He says the right side of the body, including the face, there is a decreased sensation of the touch. He cannot appreciate the cloth, whatever he is putting on the body, in the right side of the body, in the upper part and the lower part. And while taking bath, the hot and cold water sensation he cannot appreciate in the right side of the face and also right side of the body. He says there is a 50% reduction on the right side of the face and the body for the touch, that is for the fine touch, for the cold and for the hot water sensation in the right side of the body. There is no history of loss of smell, no blurring of vision or double vision. So this symptom is important, double vision history, okay, because the third nerve can be involved, okay, in the midbrain syndromes, okay, in the posterior circulation stroke. A third nerve can be involved in a midbrain syndrome. So history of diplopia you have to ask. He is not giving any history of diplopia. First nerve there is no symptom, no loss of smell. Second nerve there is no blurring of vision history wise. And he says there is history of numbness over the face. So the right side of the face there is a numbness, he says, and while washing the face with the hot water and cold water he cannot appreciate on the right side of the face. There is no history of difficulty in chewing. The motor part of the fifth nerve is not involved. There is no history of difficulty in chewing. There is no history of drooling of saliva or deviation of the angle of the mouth. There is no difficulty in closure of the eyes. So facial nerve symptoms is not involved in this patient. There is no history of ringing sensation in the ear. So there is no history of tinnitus. There is no history of nasal regurgitation, dysphagia or hoarseness of voice. This symptom is very important, students, especially in the brainstem syndrome, the lateral medullary syndrome. In the medulla, the 9th and 10th cranial nerve will be there. The 9th and 10th cranial nerve, nucleus ambiguous in the lateral part of the medulla. In the medulla supplies the muscles of the pharynx and the nasopharynx and the pharynx, oropharynx. So if there is any problem in this nucleus ambiguous, they will have dysphagia, nasal regurgitation, and because of the 10th cranial will be involved, they will have hoarseness of voice. This symptom is very important in this patient when we are considering a posterior circulation stroke, that to a brainstem syndrome. But this patient doesn't give any history of dysphagia, hoarseness of voice or nasal regurgitation or slurring of speech. And also there is no history of any loss of taste sensation. Loss of taste sensation is also important in the brainstem syndrome because the nucleus of tractus solitarius. The nucleus of tractus solitarius, which is a combination of the nucleus of the chorda tympani of the fifth nerve and the glossopharyngeal nerve. Glossopharyngeal nerve supplies the posterior 1/3 of the tongue, the taste sensation. The chorda tympani nerve of the facial nerve supplies the taste sensation to the anterior 2/3 of the tongue. So the chorda tympani and the glossopharyngeal nerve will supply the taste sensation, will form a tractus solitarius nucleus. if that is affected in the lateral medullary syndrome, because that nucleus is situated in the lateral part of the medulla. So if that is affected, they'll have loss of taste sensation, but this patient doesn't give any history of loss of taste sensation. There is no history of difficulty in moving the head side to side, which indicates whether any involvement of the 11th cranial nerve. There is no history of moving the bolus foot from side to side. Okay, so this history is important. Okay, for a 12th nerve involvement. Okay, whether he can move the bolus of the foot side to side, 12th nerve involvement, because the 12th nerve involvement, the 12th nerve, the hypoglossal nucleus is situated medially in the medulla, medially, okay, not in the laterally, medially it is situated. So in a medial medullary syndrome, they will have ipsilateral 12th nerve affection, ipsilateral 12th nerve affection in a medial medullary syndrome. That is why you have to ask the 12th nerve symptom, okay, right. So this patient doesn't give any history of any difficulty in moving the bolus from side to side. And there is no history of swaying to one side while walking. This history is important, whether he has any imbalance or ataxia while walking, because in a posterior circulation stroke, the cerebellum is supplied by the posterior circulation. Okay, it may be the lateral medullary syndrome or a pure cerebellar strokes. They will have ataxia and imbalance. Okay, so history of ataxia or imbalance is important. This patient doesn't give any history of swaying or imbalance. There is no history of motor weakness, students, in both the upper and lower limb. Proximal muscle weakness, it is not there. He can lift the hand above the head. Distal muscle weakness is not there. He can mix the foot and he can button and unbutton the shirt. Whereas in the lower limb, he can stand up from a squatting position. He can hold the chappal's grip properly. So there is no symptom suggestive of either proximal or distal muscle motor weakness. It is not at all present. Okay. There is no history of tremors, which can indicate the cerebellar involvement. It doesn't give any history of tremor, and as I told, there is no history of imbalance or swaying. And there is no history of hiccups. Okay, history of hiccups is also important because one of the symptoms of a lateral medullary syndrome, one of the symptoms is hiccups. So you would ask history of any hiccups. Is there? He doesn't give any history of hiccups. So the only important symptom what he gives is the one side of the body, including the face, the right side, is not able to appreciate the hot and cold water sensation and the fine touch, and numbness in the right side of the body. He also complains numbness in the right side of the body. In Kannada, he says junju, so that word he is using for the right side of the body, numbness. But because he says that symptom which is suggestive of a brainstem stroke, okay, the one side of the body there is loss of sensation, you would ask other symptoms relevant to the brainstem stroke. That's why we ask all these dysphagia, hoarseness of voice, diplopia, which indicates third cranial nerve, and 12th cranial nerve symptoms we are asked. So past history is not a diabetic or hypertensive, but the patient bystander says is having a heart rhythm problem, atrial fibrillation, they told, and is on medication for that. Okay, students, right? One of the commonest risk factor for stroke is 25% of the cases there is atrial fibrillation in old age, especially those who are more than 75 years like him. So he is suffering from atrial fibrillation. That is a past history. Then there is no past history of TIA. TIA symptoms is very important because as I discussed in the hemiplegia case, TIA will give a clue whether the stroke is embolic, thrombotic, okay, or hemorrhagic. Past history of TIAs goes in favor of a atherothrombotic stroke. TIAs you have to ask the two territories. One is the anterior circulation TIA and posterior circulation TIA. Anterior circulation TIA, AC and MCA territory. Posterior circulation, two vertebral artery joined together to form a basilar artery, and that divides into posterior cerebral artery. This thing supplies the posterior circulation. Anterior circulation TIA, usually they will complain a weakness of one hand or a facial weakness. That is an anterior circulation TIA. Posterior circulation TIA, as the posterior circulation supplies the nucleus of the midbrain, pons and medulla, the 3rd, 6th, 5th, 7th, 8th, 9th, 10th and 12th. So they will have a diplopia, ataxia, hoarseness of voice, dysphagia and nasal regurgitation. So these symptoms they may, and vertigo, okay. So these symptoms they may complain in a posterior circulation TIA. A TIA is a focal deficit which will last less than 24 hours. So this patient doesn't give any past history of TIAs, especially posterior circulation TIA. You have to ask in him because he says one side of the body there is a loss of sensation. One side of the body there is a loss of sensation. Family history, it is nothing significant. Personal history, he takes a mixed diet, normal bowel habit. sleep is adequate, appetite is normal, is not a smoker, not a alcoholic. Drug history is taking the antihypertensive amlong and telma. He told he is hypertensive, so that point I told he is not hypertensive. He is hypertensive and diabetic student. He is both hypertensive and diabetic. So he is taking the antihypertensive medicines amlong and telma, and anti-diabetic medicines, that is galvesmite, and he is taking aspirin, atorvastatin, glimepiride. So these medication he is taking. Okay. So he has a risk factor for a CVA, diabetes, hypertension, atrial fibrillation, okay, and age. So these are the risk factors which he is having to develop the stroke in this patient. So he is on medication for antihypertensive and anti-diabetic medications. Vitals, blood pressure is 130 by 80, 130 by 80, and rhythm, the pulse rhythm, students, he is in atrial fibrillation. Okay, I counted the pulse. Jom anta ಕಾಲ್ ಮಡ್ಚ್ಕೋಬೇಕಾ?
ಕಾಲ್ ಜೋಮ್ ಮಾಡ್ಬಿಟ್ಟು
ಆಯ್ತಾಯ್ತು, ಪರಲ್ಲ. Students, his pulse rate is irregular, and he is in atrial fibrillation. The pulse rate is around 100 beats per minute, and the pulse rate is irregular. Temperature is afebrile. Then top to bottom examination, there is no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, and no edema. Okay, so let us discuss with this findings and history. Let us analyze the patient, what he is suffering from. Okay, he says there is loss of sensation in one side of the body, including the face. Okay, that is since 1 week. Okay, so at the end of the history, whenever a patient gives a typical sensory symptom, then you can localize in the sensory symptom where is the anatomical problem. So let us come to the peripheral nerve, then we'll go ascend up to the brain. For example, one patient says he cannot appreciate the sensation in the hand and the leg, glove and stock anesthesia. Then the problem is in the peripheral nerve. Okay, next. So next, let us come to the, for example, in the spinal cord. For example, spinal cord, if there is a transaction at one level, for example, at T10 level, there is a transaction of the spinal cord. Then below that level, they cannot appreciate all the modalities of sensation because bilaterally both the long tracts will be affected. The posterior column, the spinothalamic tract, all the tracts will be affected bilaterally. So below that level, they cannot appreciate the fine touch, vibration, pain, and temperature. That is the transaction of the spinal cord. For example, if there is a compression of the spinal cord from one side, for example, there is a from the right side, there is a compression of the spinal cord. In that case, what happens is ipsilateral, they cannot appreciate the fine touch and vibration, whereas the contralateral body, they cannot appreciate the pain and temperature. And ipsilateral, along with the fine touch and vibration, they will have a motor weakness also. This is known as a Brown-Sequard syndrome. So in a Brown-Sequard syndrome, ipsilateral fine touch and vibration, contralateral pain and temperature, and ipsilateral motor weakness. That's a Brown-Sequard syndrome. Okay, if the pattern of sensory weakness is like that, then you can localize in the spinal cord, in the compression, hemisection of the spinal cord. For example, you have a conus medullaris, S2, S3, S4. If there is any neoplasm or any tumor or any lesion of the conus medullaris, S2, S3, S4, then perianal region, they cannot appreciate the sensation. That is known as a saddle anesthesia. So if one patient says around the perianal region I cannot appreciate the sensation, then it is a conus medullaris lesion. For example, one more patient has a syringomyelia, which is the spinal cord intramedullary expansion, a syringomyelia. At that time, what happens? Because the spinothalamic tract are very nearer to the syrinx, they will get compressed earlier, intramedullary compression. So they'll have loss of only pain and temperature, but the fine touch, vibration, which is a posterior column, that will be preserved. So the fine touch, vibration will be preserved, which is carried by the posterior column. The spinothalamic tract, which are nearer to the intramedullary lesions, they'll get affected. So then they'll have dissociate anesthesia. So if one patient says a dissociate anesthesia, then you will think of intramedullary compression like a syringomyelia. Next, let us go to the above. Okay. All these dorsal column which carries the fine touch, vibration, position sensation, that is proprioception, and spinothalamic tract which carries the pain and temperature, they all rely ultimately in the contralateral thalamus. Right side of the body, all the modalities will go and rely in the contralateral thalamus. Left side of the body, they all go and rely in the right side of the thalamus. So if right thalamus is affected, contralateral full side of the body, including the face, all modalities will be lost. All modalities will be lost. If left side of the thalamus is involved, contralateral one side of the body, all modalities will be lost. Like in our patient, he says right side of the body, including the leg and face, he cannot appreciate the fine touch, vibration, pain, temperature, all the modalities. That is thalamus, because thalamus is the ultimate relay center for all the tracts in the end. Okay, right. Suppose one patient says he cannot appreciate the pain and temperature on one side of the face, pain and temperature on the contralateral body. This is a very fantastic situation where a postgraduate student should remember like this: pain and temperature loss on one side of the face, whereas the pain and temperature on the contralateral body, you get a lateral medullary syndrome. Why you get like that? Because in lateral part of the medulla, you have a pain and temperature fibers carrying from the opposite side of the body situated. Same in the lateral part of the medulla, the descending tract of the fifth nerve which carries the pain and temperature of the ipsilateral phase runs downward from the pons till the medulla till the C2, C3. That is why ipsilateral pain and temperature of the phase will be affected, because that descending tract of fifth nerve which comes from the pons, then comes the medulla, lateral part of medulla, goes till the S2. So, if one patient says loss of pain and temperature on one side of the body, loss of pain and temperature on the contralateral body, then the problem is the lateral part of the medulla. Suppose, if one patient has only an examination, I am telling an examination, only cortical sensation is lost, but all the fine modalities, fine touch, vibration, position sensation, everything is normal, pain and temperature, if everything is normal, only cortical sensation is affected, then the problem is in the parietal sensory cortex. So, very simple, students, come from peripheral nerve, go till the cortex. The pattern of deficit, what the patient is having, the pattern of loss, what the patient is having, then you can able to localize. So, our patient says one side of the body, total loss of sensation for all the modalities. So, right side, so including the face, so we have to suspect the anatomical localization in the left thalamus, and it is acute onset, so it is cerebrovascular accident. He is having a atrial fibrillation, so probably a embolic lesion on the left thalamus, producing a thalamic infaction. What are the other DDs you can consider? Is it a lateral medullary syndrome? Lateral medullary syndrome, as I told, one side of the face, contralateral body should be pain and temperature should be lost. Other symptoms of lateral medullary syndrome like cerebellar ataxia, nasal regurgitation, hoarseness of voice because of nucleus ambiguous involvement, loss of taste sensation because of tractus solitarius, all vertigo, all these things should have been there if it's a lateral medullary syndrome. Lateral medullary syndrome will be kept for a PG exam students. That is why I am discussing this case. Okay, suppose if this patient would have told right side of the face loss of pain and temperature, opposite side of the body there is a loss of pain and temperature, along with cerebellar signs on the right side with the symptoms of cerebellum, along with nasal regurgitation, hoarseness of voice, or a giddiness, with the Horner syndrome on the right side, then you should think of a lateral medullary syndrome, which I'll discuss again at the end of the discussion, okay, about the lateral medullary syndrome. In the history wise, we cannot think in these patients, okay, but lateral medullary syndrome or a Pica syndrome or a Wallenberg syndrome or other names will be definitely kept for the exam if that case is there for a PG exam. So, the other Pontine syndromes, why it cannot be in this case, okay, I'll discuss when I discuss at the end of the examination the Pontine syndromes. We cannot think in this case. I'll discuss in the end why we cannot think all those things in this case. But because one side of the body there is loss of sensation, automatically our anatomical side will become thalamus. So the vitals, the one important points, as I told, he has an irregular pulse, is an atrial fibrillation, okay. And top to bottom, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. So, coming to the central nervous system examination, higher mental function, orientation, registration, attention, calculation, recall, language, everything is normal in him. The cranial nerves, the first cranial nerve is normal, it is not affected. Second cranial nerve, visual acuity, 6/6, visual field is normal, fundus is normal, pupillary response is normal. Pupillary reflex is very important in this case, students, because in a lateral medullary syndrome, lateral part of the medulla, the sympathetic chain runs. The sympathetic chain runs in the lateral part of the medulla. So, lateral medullary syndrome will have a Horner syndrome with a miosis. That is a pupillary reflex, and pupillary size is important in this case. Color vision is normal. The third, fourth, and sixth cranial is important in this case because the extraocular movements, the third cranial will be involved in one of the posterior circulation stroke because ipsilateral third nerve palsy with a contralateral hemiplegia, that is a Weber syndrome, it is a midbrain syndrome. Similarly, ipsilateral third nerve palsy with contralateral ataxia is a Claudius syndrome. For these two syndromes, third nerve examination is important. Let me examine the extraocular movements in him. Let us examine the third, fourth, and sixth cranial, the extraocular movements. ಮುನಿಯಪ್ಪನವರೇ ನಾನು ಬೆರಳೆ ನೋಡ್ಬೇಕು ನಾನು ಹೇಳಿದಾಗ ಬೆರಳು ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಕೆಳಗೆ ನೋಡಿ, ಕತ್ ಕೆಳಗೆ ನಾವು ಬರೀ ಮುಖ ಕೆಳಗಡೆ ತರಬಹುದು, ಕಣ್ಣು ಮಾತ್ರ ಕೆಳಗಡೆ ನೋಡಿ, ಕಣ್ಣು ಮಾತ್ರ, ಈ ಸೈಡ್ ನೋಡಿ, ಮೇಲ್ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಬರೀ ಕಣ್ಣು ಮಾತ್ರ, ಈ ಸೈಡ್ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ. Yes, so there is no nystagmus and the extraocular movements are normal, okay, and pupilla is also normal, so third nerve is not affected. Third nerve examination is important as I told because the two midbrain syndromes, Weber syndrome and Claudius syndrome, for that it is important. And Benedict syndrome is a combination of that according to the De Jong, but some other book gives in some other way, but I will prefer De Jong, so it's a combination of Claudius and Weber syndrome, Benedict syndrome. So next, coming to the fifth nerve examination. Fifth nerve examination is important, students, because as I told in a lateral medullary syndrome, ipsilateral face pain and temperature will be affected, contralateral body pain and temperature will be affected. Whereas in a thalamic infarction, full side of the body, whichever side that the contralateral thalamus is involved, so one side of the body, including the face, all the modalities will be lost. Let me examine him on the face, both right side and left side, fine touch, pain. ಮುನಿಯಪ್ಪನ ಕಣ್ಣು ಮುಚ್ಕೋಬೇಕು, ಇದು ಮುಟ್ದಾಗ ಗೊತ್ತಾದ್ರೆ ಒಂದು ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಆಪ್ಥಾಲ್ಮಿಕ್ ಡಿವಿಷನ್ ಐ ಆಮ್ ಟೆಸ್ಟಿಂಗ್.
ಒಂದು 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 ಒಂದು
ಆಯ್ತು. ಈಗ ಬಲ್ಗಡೆ ಎಡಗಡೆ ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಾ ಇದೆಯಾ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ಬಲಗಡೆ ಸ್ವಲ್ಪ ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎಷ್ಟು ಕಮ್ಮಿ ಇದೆ?
0.5% ಕಮ್ಮಿ.
Good. So it's telling right side there is a 25% reduction in the fine touch. Okay, students. Okay. Let me examine the pain. ಕಣ್ಣು ಮುಚ್ಚಿ.
ಒಂದು 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 ಒಂದು
ಎರಡು ಕಡೆ ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಾ ಇದೆಯಾ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಯಾವ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಎಡಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ಬಲ್ಗಡೆನಾ ಎಡಗಡೆನಾ?
ಎಡಗಡೆ ಕಮ್ಮಿ ಇದೆ, ಬಲಗಡೆ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ.
ಬಲ್ಗಡೆ ಕಮ್ಮಿ ಇದೆ, ಬಲ್ಗಡೆ ಕಮ್ಮಿ ಇದೆ, ಎಡಗಡೆ ನಾರ್ಮಲ್ ಇದೆ. ಈ ಸೈಡ್ ಕಮ್ಮಿ ಇದೆ, ಬಲ್ಗಡೆ ಎಷ್ಟು ಪರ್ಸೆಂಟ್ ಕಮ್ಮಿ ಇದೆ?
ಒಂದು 0.5%
ಕಮ್ಮಿ ಇದೆ. Okay, so you see right side there is a reduction in the pain sensation. Okay, students, right. Coming to the seventh nerve examination. So seventh nerve examination is also important, students, because the seventh nerve examination will be involved in some of the brainstem syndromes. Okay, let me examine quickly the seventh nerve examination. ನನ್ನ ಬೆರಳು ನೋಡಿ ಮೇಲೆ. ಓಕೆ, ಕಣ್ಣು ಟೈಟಾಗಿ ಮುಚ್ಚಿ. ಸಾಕು. ಹೀಗೆ ಮಾಡಿ, ಹಿಂಗೆ ಗಾಳಿ ಇಟ್ಕೋಬೇಕು. ಹಲ್ ತೋರಿಸಿ ಹಿಂಗೆ. ಓಕೆ, ರೈಟ್. The seventh nerve examination is normal. The motor system examination is normal. Even sensory part is also normal. You can appreciate the taste sensation, okay, in the tongue which I have examined in. Eighth nerve, the Rinne's AC is better than BC. Weber's is equal on both the sides. The ninth and 10th, very important, students, in this case, because the gag reflex is very important, because lateral medullary syndrome, one of the brainstem syndromes, for example, ipsilateral, if 10th is involved, it behaves like a 7th nerve only. For example, if right side 10th nerve is involved, the uvula will deviate towards the left side, okay, like a 7th nerve. If right side 7th nerve is paralyzed, the angle of the face will deviate towards the normal side. Same 10th nerve also, okay. Let me examine the gag reflex in him, because that is very important, because we are considering is a PCA stroke, a brainstem stroke. That is why that reflex is important. Gag reflex is normal, students. The uvula is lifted upwards. It is normal. There is no deviation of uvula either to the right side or left side. Gag reflex is normal. Very important reflex in a brainstem syndrome, students. The tongue examination again important. Okay. Before that the 11th nerve and then the 12th nerve. Okay. The 11th nerve examination, the movement of the chin again as the resistance is normal. Shrugging of the shoulder is normal again as the resistance. 11th nerve is not involved. The tongue important because in the medial medullary syndrome, because the 12th nerve is situated medially, ipsilateral 12th nerve will be involved, and contralateral the fine touch vibration and contralateral motor weakness will be involved. Students, in a lateral medullary syndrome, the motor weakness won't be there. The motor weakness won't be there in a lateral medullary syndrome because the corticospinal tract is situated medially. That is why lateral medullary syndrome is known as inobvious stroke. Only they'll have giddiness, what I go, they hesitate to sit up. So a doctor will come for a rounds. He'll just ask the patient to lift the hand. He will lift the hand, lift the leg. Patient will lift the leg. So no weakness. Doctor will think he is normal. He'll go to the next bed. So it is known as inobvious stroke, lateral medullary syndrome. Whereas a medial medullary syndrome, ipsilateral 12th nerve, contralateral corticospinal tract, contralateral fine touch and vibration, because the corticospinal tract and medial meniscus are situated medially. Now let me examine in him the 12th nerve examination. ಮುನಿಯಪ್ಪನವ್ರೆ ನಾಲ್ಗೆ ಹೊರಗಡೆ ಹಾಕಿ ಮಾಡಿ ನಾಲ್ಗೆ ಮೇಲ್ ಮಾಡಿ ಹಿಂಗೆ ಹಿಂಗೆ ಸೈಡ್ ಮಾಡಿ ಹಿಂಗೆ ಓಕೆ. ಮುನಿಯಪ್ಪನವ್ರೆ ನಾಲ್ಗೆ ಇದೆಯಲ್ಲ ಹಂಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಫುಲ್ ಟೈಟಾಗಿ ಇಟ್ಕೋಬೇಕು. Unable to move the tongue against the cheek. Okay, the 12th nerve examination is absolutely normal. Okay, right. So let us go to the examination of the motor system, students. This is a cranial examination. Let me go to the examination of the motor system. As I told, in a lateral medullary syndrome, the power will be normal. There won't be any motor weakness. As well as in a thalamic infaction, students, okay, there will be a sensory affection on the contralateral body, but because internal capsule runs very close to thalamus, because of the edema, initial stage of the edema, there can be a mild hemiparesis because of the pressing on the internal capsule. Let us see what has happened in him, the motor system examination. Attitude, supine position, arms by the side of the body. The nutrition, there is no wasting, it is normal. The tone, the right side it is normal, upper limb and lower limb. Left side upper limb and lower limb it is normal. The power, the right upper limb it is 5/5. The left upper limb it is 5/5 in all the joints, shoulder joint, elbow joint, all the muscles it is normal. Hand grip is normal. The power in the lower limb, right side it is 5/5 in the hip joint, knee joint and the ankle joint. And the power in the lower limb, hip joint, knee joint, ankle joint, all the muscles it is normal. So there is no motor weakness in this patient. Coordination, students, the coordination is important in this case because we are considering lateral medullary syndrome. Okay, so coordination examination is important, and he is not having the coordination problem. The finger nose test, the dysdiadochokinesia is not there. Let me examine those things in him now. Okay, students, let me examine on him some important cerebral signs. Okay, right. ಮುನಿಯಪ್ಪನವರೇ ಈ ಥರ ಮಾಡಿ ಮೂಗು ಮುಟ್ಕೊಂಡು ಕೈನ ಬಲಗೈಯಲ್ಲಿ ಮಾಡಿ ಮೂಗು ಮುಟ್ಕೊಳ್ಳಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ, ನಕೈ ಸಲ ಮಾಡಿ, ಗುಡ್. ಈ ಕೈಯಲ್ಲಿ ಮಾಡಿ ನಕೈ ಸಲ ಮಾಡಿ, ಓಕೆ ಸಾಕು. ಈ ಥರ ಮಾಡಿ, ಡಿಸ್ಡೈಡೋಕೋಕೈನೇಸಿಯಾ ಮಾಡಿ, ಫಾಸ್ಟಾಗಿ ಮಾಡಿ, ವೆರಿ ಗುಡ್. ಈ ಕೈಯಲ್ಲಿ ಮಾಡಿ, ಫಾಸ್ಟಾಗಿ ಮಾಡಿ, ನಾಲ್ಕೈದು ಸಲ ಮಾಡಿ, ಯು ಕ್ಯಾನ್ ಡೂ ಇಟ್. ಲೆಟ್ ಮಿ ಎಕ್ಸಾಮಿನ್ ದ ರಿಬೌಂಡ್ ಫಿನಾಮಿನಾ. ಈ ಕೈ ಇದೆಯಲ್ಲ ಈಗ ಮಡ್ಚ್ಕೋಬೇಕು, ನಾ ಹಿಡ್ಕೋಬೇಕು, ನೀವು ಮಡ್ಚಿ, ಹಂಗೆ ಗುಡ್. ಮಡ್ಚಿ ಎಷ್ಟಾಗುತ್ತೆ ಎಷ್ಟು ಮಡ್ಚಿ, ಓಕೆ. ಇದು ಹಾಗೆ ಮಡ್ಚಿ. So the Holmes rebound phenomena. Let me examine the lower limb, some of the important signs in the lower limb. Let me do the knee heel test. ಮುನಿಯಪ್ಪನವರೇ ನಾನು ಹೇಳಿದ್ನಲ್ಲ, ಈ ಕಾಲು ಇಲ್ಲಿಂದ ತೆಗೆದು ಹಿಂಗೆ ಇಡಬೇಕು. ನಾನು ಮಾಡ್ತೀನಿ ಒಂದ್ಸಲಿ, ಹಿಂಗೆ ತೆಗೆದು ಇಲ್ಲಿ ಇಡಬೇಕು. ನಾಲ್ಕೈದು ಸಲ ಮಾಡಿ, ಆ ಥರ ಮಾಡಿ, ಇನ್ನೊಂದ್ಸಲ ಮಾಡಿ, ಗುಡ್ ಸಾಕು. ಈ ಕಾಲಲ್ಲಿ ಮಾಡಿ, ಇನ್ನೊಂದ್ಸಲ ಮಾಡಿ. Yeah, student, fairly it is normal. Why cerebellum system examination is very important is because, students, ipsilateral lateral medullary syndrome, that side there will be involvement of the cerebellum system involvement. Okay, so ataxia is an important symptom of lateral medullary syndrome. If is one of the important brainstem syndrome which will be kept for PE exam. So cerebellum system examination is very important in lateral medullary syndrome. Okay, right. Coming to the reflexes, superficial reflexes, corneal, conjunctival, cremasteric is normal. Okay, it's present, and plantar bilaterally flexor. Abdominal reflex is also present. Corneal, conjunctival, abdominal, cremasteric reflex is present, and plantar is bilateral flexor. Plantar I will elicit again, very important. So plantar, let me elicit. Flexor, students, you can make out flexor. ಏನು ಮಾಡಲ್ಲ ಸುಮ್ಮನೆ ಇರಿ. So withdraw all this right side. Getting withdrawal. On this side it is flexor. Okay, right. Plantar reflex is very important because in a lateral medullary syndrome, okay, you won't get corticospinal tract involvement because it's situated medially. It's situated medially. And here he says right side of the body there is a loss of sensation, one full right side of the body. Here also corticospinal tract won't be involved unless there is the edema, the thalamus edema may be pressing. For example, now right side there is a loss of sensation of the whole of the body. Now we are considering the left thalamus as the problem anatomically. So left internal capsule with the thalamic infaction as pressed on the internal capsule. Then right side there will be a motor weakness with the plantar extensor. But here the power is normal, right upper limb and lower limb 5/5, okay. And right side we are getting a withdrawal because it's little hypersensitivity, because the thalamic infarction patient, they will have a severe pain, they will have severe pain and loss of sensation to all the modalities. It is known as anesthesia dolorosa, which I will be examining in the sensor system and I will tell you, okay. But the plantar left side it is flexor, right side we are getting a withdrawal. Coming to the deep tendon reflexes, upper limb. Deep tendon reflexes, let me examine the students. Right side biceps is present, brachioradialis is also present, triceps present. ಆರಾಮಾಗಿದೆ ಬಿಡಿ, ಆರಾಮಾಗಿದೆ. Okay. Present students, you can make out the triceps present. Biceps is also present. Let me examine in the lower limb deep tendon reflexes. ಕಾಲು ಮರ್ಚ್ಕೊಳ್ಳಿ, ಆರಾಮಾಗಿರಿ. ಬೆಳಗ್ಗೆ ಏನು ತಿಂಡಿ ತಿಂದ್ರಿ? ಲೂಸ್ ಬಿಡ್ಬೇಕು, ಕಾಲು ಟೈಟಾಗಿ ಹಿಡಿಬಾರ್ದು. ಹಲ್ಲು ಕಚ್ಚಿ ಬಿಗಿ ಟೈಟಾಗಿ, ಹಲ್ಲು ಕಚ್ಚಿ ಟೈಟಾಗಿ, ಹಲ್ಲು ನಿಮ್ಮ ಹಲ್ಲು is holding it tight, students. Is holding it tight. That's why not able to get the reflex. Okay. ಬಿಡಿ, ಕಾಲು ಮರ್ಚ್ಕೊಳ್ಳಿ. ಆಗಲ್ಲ, ಹಿಂಗೆ ಆಗಲ್ವಾ ಮರ್ಚಕ್ಕೆ ಈ ಥರ ಕಷ್ಟ. ಓಕೆ, ಈಸ್ ಹ್ಯಾಂಗ್ ಹಿಪ್ ಪ್ರಾಬ್ಲಮ್, ದಟ್ಸ್ ವೈ ಅನೇಬಲ್ ಟು ಫ್ಲೆಕ್ಸ್ ದೇರ್ ಟು ಎಲಿಸ್. ಸಾಕ್ಬಿಡಿ, ಆರಾಮಾಗಿರಿ. ಸಾಕು, ಕಾಲು ನೇರ ಮಾಡಿ. Upper limb, the DTR are present, students. Lower limb is holding it tight. Tendency maneuver, unable to convince him because he is a rural patient. Okay, yeah. So we'll keep that like that. Okay. Next, coming to the sensory system examination. Okay. Let me examine the fine touch, the carried by the posterior column, the vibration sensation, position sensation, joint position sensation, and then pain and temperature carried by the spinal thalamic tract. Let me examine the fine touch, students, first. So the dermatomal distribution, students, as I explained in the peripheral neuropathy, C1 doesn't have any sensory supply outside the body, it supplies the posterior cranial fossa. C2 is the angle of the jaw. C3 and C4 cervical plexus. C5 here the deltoid. C6, C7 lateral part of the forearm. C8 the middle finger. T1 the medial part of the forearm. T2 upper part of the arm, medial part. T4 the nipple. T8 epigastric region. T10 umbilicus. T12 suprapubic. L1 you stand with both your hands in your pocket, the pant pocket, that is L1. L2, L3 is the knee, L3. L4 is medial part of the leg. L5 is lateral part of the leg. S1 dorsum of the foot. S2 is a one column posteriorly in the leg, a thin column posteriorly in the leg. Then S3, S4, S5 surrounding the anus. So in these dermatomals I will be examining now. Okay. Let us see what has happened to his sensation. So I explained the dermatomal distribution, students. Let me examine the sensory system on him. ಇದು ಮುಟ್ದಾಗ ಗೊತ್ತಾದ್ರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು.
ಒಂದು ಒಂದು ಒಂದು
ಎರಡೂ ಕಡೆ ಒಂದೇ ತರ ಇದೆಯಾ ಅಥವಾ ಕಮ್ಮಿ ಇದೆಯಾ? ಬಲಗಡೆ ಅಥವಾ ಎಡಗಡೆ ಕಮ್ಮಿ ಇದೆಯಾ?
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ವೆರಿ ಗುಡ್. ಓಕೆ, ಎಷ್ಟು ಕಮ್ಮಿ ಇದೆ ಬಲಗಡೆ?
ಕಾಲ್ಬಾರು.
ವೆರಿ ಗುಡ್. ಗೊತ್ತಾದ್ರೆ ಒಂದು ಅಂತ ಹೇಳಿ.
ಒಂದು 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 ಒಂದು
ಎರಡು ಕಡೆ ಗೊತ್ತಾಗ್ತಿದ್ಯಲ್ಲ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ ಒಂದೇ ತರ ಇದೆಯಾ ಬಲಗಡೆ ಎಡಗಡೆ?
ಇಲ್ಲ, ಬಲಗಡೆ ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎಷ್ಟು ಕಮ್ಮಿ ಇದೆ ಬಲಗಡೆ?
ಕಾಲ್ಬಾರು ಕಮ್ಮಿ ಇದೆ.
ಓಕೆ, ಈ ಸಲ 25% ರಿಡಕ್ಷನ್.
ಒಂದು ಒಂದು
ಮೇಲೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಹಾಗೆ
ಒಂದು 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 ಒಂದು
ಎರಡು ಕಡೆ ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಾ ಇದೆಯಾ ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎತ್ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ಸರಿ.
ಒಂದು 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 ಒಂದು
ಎರಡು ಕಡೆ ಗೊತ್ತಾಗ್ತಿದೆಯಲ್ಲ, ಒಂದೇ ತರ ಇದೆಯಾ ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಸೊ ಲೆಟ್ ಅಸ್ ಎಕ್ಸಾಮಿನ್ ದ ಪೇನ್ ಸೆನ್ಸೇಷನ್ ಆನ್. ಮುಂದೆ ಬಂದ್ರೆ ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. ಗೊತ್ತಾದ್ರೆ ಒಂದು ಅಂತ ಹೇಳಿ.
ಒಂದು 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 ಒಂದು
ಎರಡು ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಿದೆ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎತ್ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಬಲಗಡೆ ಕಮ್ಮಿ.
ಗುಡ್. ಓಕೆ, ಹೇಳಿ ಒಂದು ಗೊತ್ತಾಗ ಹೇಳಿ.
ಒಂದು 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 ಒಂದು
ಮುರಿದಾಗ ಮಾತ್ರ ಹೇಳಿ.
ಒಂದು ಒಂದು
ಗುಡ್.
ಒಂದು 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 ಒಂದು
ಗೊತ್ತಾಗ್ತಿದ್ಯಾ ಒಂದು ಅಂತ ಹೇಳಿ.
ಒಂದು 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 ಒಂದು
ಎರಡು ಕಡೆ ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಿದೆ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎತ್ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ಎಷ್ಟು ಪರ್ಸೆಂಟ್ ಕಮ್ಮಿ ಇದೆ?
4% ಕಮ್ಮಿ ಇದೆ.
Okay, right. So he's telling there is a pain sensation reduction on the right side around 25% and the fine touch is also reduced. Let me examine the vibration and joint position sensation. ಇದು ಗೊತ್ತಾದ್ರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಗೊತ್ತಾಗ್ತಿದ್ಯಾ?
ಒಂದು ಒಂದು
ಎರಡು ಕಡೆ ಒಂದೇ ತರ ಇದೆಯಾ ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎತ್ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ಎರಡು ಕಡೆ ಒಂದೇ ತರ ಗೊತ್ತಾಗ್ತಿದೆ, ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ವ್ಯತ್ಯಾಸ ಇದೆ.
ಎತ್ ಕಡೆ ಕಮ್ಮಿ ಇದೆ?
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ.
ಬಲಗಡೆ ಕಮ್ಮಿ ಇದೆ ಅಲ್ವಾ? ಓಕೆ, ರೈಟ್. ಈಗ ಕಣ್ ತೆಗಿರಿ. ಓಕೆ, ನಾನು ಈ ಕೈನ ಯಾವುದೋ ಒಂದು ಪೊಸಿಷನಲ್ಲಿ ಇಡ್ತೀನಿ. ನೀವು ಆ ಕೈನ ಅದೇ ಥರ ಇಟ್ಕೋಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಓಕೆ, ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. ಬಲ್ಗೈ ಯಾವ ಥರ ಇಟ್ಟಿದ್ದೀನಿ, ಎಡಗೈ ಅದೇ ಥರ ಇಟ್ಕೊಳ್ಳಿ. ಎಸ್. ಸೊ ಪೊಸಿಷನ್ ಸೆನ್ಸೇಷನ್ ಈಸ್ ನಾರ್ಮಲ್. ಲೆಟ್ ಮಿ ಎಕ್ಸಾಮಿನ್ ದ ಜಾಯಿಂಟ್ ಪೊಸಿಷನ್ ಸೆನ್ಸೇಷನ್. ಆಯಿತು, ಕಣ್ಬಿಡಿ. ಮುನಿಯಪ್ಪನವರೇ ನೋಡಿ, ಇದು ಕೆಳಗಡೆ, ಇದು ಮೇಲೆ, ಇದು ಕೆಳಗೆ, ಇದು ಮೇಲೆ. ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. ಕೆಳಗಿದೆಯಾ ಮೇಲಿದೆಯಾ? ವೆರಿ ಗುಡ್. ಕೆಳಗಿದೆಯಾ ಮೇಲಿದೆಯಾ? ಯಾ. ಸೊ ಜಾಯಿಂಟ್ ಪೊಸಿಷನ್ ಸೆನ್ಸೇಷನ್ is also normal in it. Position sensation is also normal in it. So there is a decreased sensation, 28% reduction for the fine touch, vibration and also for the pain sensation. So all the modalities from the face, right side of the body, it is reduced. The gait, so it is normal students, his gait, skull and spine is also normal. Autonomic nervous system, it is normal, no orthostatic hypotension. Respiratory system examination, bilateral vesicular, normal vesicular breath sounds are heard. Cardiovascular system examination, as I told, he has atrial fibrillation, irregular pulse. And also, you have to look for any bruising in the carotid artery in these sort of cases because of the stroke which we are suspecting. Per abdomen soft and it is no organomegaly. So what are the positive findings we got at the end of examination, students? The right side of the body, there is loss of sensation to all the modalities, fine touch, vibration, joint position and pain and temperature. Joint position is normal, but the pain and temperature, the fine touch and the vibration is reduced 25% on the right side. So right whole side of the body it is affected. Cranial is normal, DTR are also normal, plantar is flexor, motor power examination is normal. So classically splitting into a left thalamic infarct and left thalamic probably embolic stroke and an infarct. Okay, so that is the diagnosis at the end of the examination. Right. And they did MRI after this examination, students. MRI classically showed infarction in the thalamic region, which I'll be showing in the PPT, okay, the thalamic infarction and how it will look, okay, right. The patient is having a numbness, students. He is having a numbness on the right side of the body. He is telling me again and again, not able to lie down. He wants to go. So I'll make him lie down there and I'll discuss the thalamic stroke detail in the brainstem stroke detail. Okay, let us not trouble him. This is known as the Digery and Rusi syndrome. The Digery and Rusi, okay, thalamic anesthesia dolorosa. They have a loss of sensation of the right side of the body, 25%, but intolerable pain will be there. You can make out his right leg. He is moving it up and down, because they'll have intolerable pain. That is anesthesia dolorosa. Dolorosa is pain. Anesthesia is while touching, while examining, there'll be loss of sensation. Anesthesia dolorosa, Digery and Lucy. So he's telling me again and again he wants to go there. I'll send him and then I'll discuss the brainstem stroke, the posterior circulation stroke. Okay, students? Right. Okay, students, let me discuss a posterior circulation stroke in detail, because these are little rare and a postgraduate student should know this, and a case will be kept if this case is there in your final practical exam. This may not be kept for undergraduate level, but postgraduate level, posterior circulation stroke is important. First, let me discuss the blood circulation, the anatomy, and then let me go to the etiology of the strokes, and then the syndromes, the posterior circulation syndrome at each level, what you get it. So the posterior circulation includes the two vertebral artery will join together to form a basilar artery, and the basilar artery will divide into two posterior cerebral artery. The two vertebral artery, student, the right side of the vertebral artery will arise from the right innominate artery. The left side of the vertebral artery will arise from the subclavian artery. The vertebral artery is divided into four segments, okay. From the origin till the C5 or C6 vertebra is the first segment. The second segment is from C5, C6 vertebra till the C2 segment is the second part of the vertebral artery. Then the third part of the vertebral artery is from C2, it goes till the foramen magnum. It pierces the foramen magnum into the brain. That is the third part. Then the fourth part is the one which supplies within the brain by giving the branches. Okay, right. So only the fourth part of the vertebral artery will supply the brain. The branch of the vertebral artery which supplies the brain is posterior inferior cerebellar artery. The posterior inferior cerebral artery, the proximal part will supply the lateral part of the medulla, whereas the distal part will supply the inferior part of the cerebellum. Then you have a basilar artery. Basilar artery will give a paramedian branches. These paramedian branches will supply the medial part of the pons. Then you have a short circumferential branches. The short circumferential branches will supply the lateral two-thirds of the pons. The long circumferential branches are only two important. One is anterior inferior cerebellar artery and superior cerebellar artery. So paramedian branches, short circumferential branches, long circumferential branches. The long circumferential branches are two: anterior inferior cerebellar artery and superior cerebellar artery. So posterior inferior cerebellar artery is a branch of vertebral artery, whereas an anterior inferior cerebellar artery is a branch of basilar artery. Then you have a posterior cerebral artery. Posterior cerebral artery is divided into two parts: P1 segment or a central territory, P2 segment or a peripheral territory. The P1 segment is the one before the posterior communicating artery, okay, before the posterior communicating artery, which communicates the posterior cerebral artery with the anterior carotid artery, okay. That is the P1 segment. The P2 segment is after the posterior communicating artery, The P1 segment, the central posterior cerebral artery, supplies the thalamus, the subthalamic nucleus and the midbrain, whereas the P2 segment or the peripheral territory supplies the occipital lobe, the inferior part of the temporal lobe, occipital lobe. So the P1 segment and the P2 segment of posterior cerebral artery. So this is the blood circulation of the posterior circulation system, the anatomy of the posterior circulation. Okay. Now, let us go to the etiology of the ischemic stroke and the hemorrhagic stroke, which I have already discussed in the hemiplegia case, but I want to just revise once. So, what are the causes of ischemic stroke? Okay, the causes are first is the thrombotic stroke. Thrombosis can occur in a large blood vessel within the ACA, PCA, vertebral artery, MCA, thrombosis can occur, or there can be a thrombosis of the very small vessels known as a lacunar stroke. Thrombosis of the small vessels or a dehydration. These are the causes of thrombosis. Then embolic. What are the common causes of embolic stroke? Atrial fibrillation, like in our patient who is having atrial fibrillation, mitral stenosis, myocardial infarction, cardiomyopathy, infective endocarditis. So they can have a embolism. This is cardioembolic. Embolic source is within the heart. Or embolism can be from artery to artery, one artery to the other artery. For example, if there is a big thrombus in the common carotid artery bifurcation, embolism can be thrown. So, common carotid artery bifurcation or an arch of aorta or an arterial dissection can produce an embolism. So, arterial dissection, common carotid artery bifurcation and aortic arch. Then you can have a paradoxical embolism like in an atrial septal defect, patent foramen oval, or atrial septal aneurysms. You can have a paradoxical embolism. Then the drugs like cocaine and amphetamine can produce a thrombosis and spontaneous echo contrast within the left atria, which you get in mitral stenosis. These are some common causes of a ischemic stroke. Then which are the uncommon causes for ischemic stroke? The hypercoagulable states like protein C, proteinase deficiency, factor V lesion, prothrombin gene mutation, oral contraceptive pills, systemic malignancies, nephrotic syndrome, inflammatory bowel disease. All these things can produce a hypercoagulable state and homocystinemia. Then the hematological causes like thalassemia, sickle cell anemia, polycythemia vera can produce a thrombosis and stroke. Then you have cortical venous thrombosis. Then you have fibromuscular dysplasia, which can produce a ischemic stroke. Then vasculitis. Vasculitis, there are three types. It could be due to infections like tuberculosis, fungal, bacterial, herpes zoster. Or it could be a primary CNS vasculitis. Or a systemic vasculitis like polyarteritis nodosa, vaginous granulomatosis, Takayasu disease, joint cell arteritis. So this can produce a ischemic stroke. Then you have some uncommon causes of from the heart like mitral annular calcification, atrial myxoma, or any other cardiac tumors, Liebman-Sack endocarditis, or a Marantic endocarditis, which you get in malignancy, Liebman-Sack, which you get in SLE. This can produce a ischemic stroke. And other rare causes are subarachnoid hemorrhage can produce a vasospasm, moya disease can produce, and eclampsia can produce a stroke. Then you have a non-inflammatory vasculopathy. The causes are Fabry's disease, angiocentric lymphoma, and reversible vasoconstriction syndromes. These are the causes which are given in the Harrison for the ischemic stroke. Then what are the causes of a hemorrhagic stroke? A trauma is the commonest cause for hemorrhage, traumatic stroke. And then drugs like anticoagulant drugs, overdosage, warfarin, thrombolytics, or a coagulopathy, hemophilia, or ITP, they can bleed. Then if there is a large infarction is there, that can transfer into a hemorrhagic stroke. Secondaries, for example, bronchogenic carcinoma, renal cell carcinoma can metastasize, then they may bleed in the brain. Secondaries. Then you have AV malformations, cavernous angioma, capillary telangiectasias can bleed in the brain. Then dural AV anastomosis also can bleed in the brain. These are some of the causes of intracerebral hemorrhage. Now, what are the brainstem syndromes, the posterior circulation syndromes that you get? Okay, we'll go from above downwards so that it will be easy for you to understand. Okay, first we'll discuss the posterior cerebral artery. Then I'll go one by one down. What are the posterior circulation strokes you get? In a posterior cerebral artery, students, there are two I told. One is a P1 segment, which is a central territory, and a P2 segment, which is a peripheral territory. The P1 segment, students, as I told, it supplies the thalamus, subthalamic nuclei, then midbrain. So, what are the clinical features? Thalamus. So, if there is thalamic infarction, as I told in our patient, is a thalamic infarction. One side, if right side thalamus is involved, contralateral one side of the body, all modalities will be lost because thalamus is the ultimate relay center for all the modalities. And thalamic infarction or a hemorrhage can press on the adjacent internal capsule. They may have hemiparesis on the contralateral side. Then if subthalamic nucleus is involved, they will have hemibalismus. Subthalamic nucleus is involved in that. So if there is any subthalamic nucleus, they can have hemibalismus on the contralateral side. Then one more artery will be given in a P1 segment, artery of Percoran. If artery of Percoran is involved, they will have a vertical gaze palsy along with ebulia. Then P1 segment supplies the midbrain. So midbrain, because it supplies, as I told, there will be three important syndromes. One is Weber's syndrome, ipsilateral third nerve palsy, contralateral hemiplegia, or ipsilateral third nerve palsy with a contralateral ataxia. Ipsilateral third nerve palsy with the Weber syndrome, because the ipsilateral third nerve will be affected, and contralateral cerebral peduncle will be affected. Claudius syndrome, ipsilateral third nerve will be affected, contralateral dentado-thalamotract will be affected, or they may just have a rubral tremor on the contralateral side because of the rubral tract will be affected, dentado-rubro-thalamic tract. Or a combination of a Weber's and a Claudius, a Benedict syndrome can occur. So these are the things which you get in a P1 segment. The P2 segment, which supplies the occipital lobe and the inferior part of the temporal lobe. What are the clinical features you get in a P2 segment? If a unilateral affection is there of a PCA territory, because the temporal lobe is inferior and optic radiation can be involved in the temporal lobe, there are superior quadrantanopia, homonymous hemianopia, especially superior they will have. If bilateral occipital lobe is involved, then they will have a cortical blindness where a pupillary reflex will be normal, and they deny that they are having blindness, that is Anton syndrome. Cortical blindness and Anton syndrome. They will have color blindness, they will have difficulty in counting and enumerating the objects. A to and fro movements they won't be able to make, or to and fro movements, and gun barrel vision, only the objects which are centrally situated they can see, not the objects which are situated peripherally, gun barrel vision. And if the visual association areas are affected in a bilateral occipital lobe infarction, they will have a Balin syndrome. Balin syndrome means inability to scan the peripheral objects. Balin syndrome. Then they'll bump into things which they see and try to avoid it. These are the things which you get in bilateral occipital lobe infarction. If a dominant hippocampus or a bilateral hippocampus is involved, they will have memory disturbance. Memory disturbance is usually transient because the recovery usually occurs in that. If a dominant calcarine cortex with the posterior part of the corpus callosum is involved, they will have dyslexia without agraphia along with the color anomia. Dyslexia without agraphia along with color anomia if a dominant calcarine cortex along with the posterior part of the corpus callosum. Then there are topographic disorientation and prosopagnosia. Prosopagnosia is inability to recognize the face if a non-dominant calcarine cortex is involved. Non-dominant calcarine cortex, prosopagnosia and topographic disorientation. If a dominant calcarine cortex is involved, they will have visual neglect. A visual neglect will be there, and simultanagnosia. What is simultanagnosia? If you take them to a forest, they'll see only trees. They can't say it is forest. Simultaneous image, they won't be able to perceive. They'll just say it is tree, but not a forest. So simultanagnosia, hemivisual neglect will be there in a dominant calcarine cortex. Then, if the calcarine cortex is involved, there are other features like metamorphopsia. Metamorphopsia means a straight line will appear as a zigzag line. Then, there are telopsia. Telopsia means the objects will appear farther away from what they are really. That is telopsia. Then palinopsia. Palinopsia is the images will persist even if they are seeing the other object. For example, now I will be seeing this. Then if I move my eye to this, that image will persist in my retina rather than a new image. That is palinopsia. Palinopsia, telopsia, metamorphopsia if calcarine cortex is involved. Then if non-dominant occipital lobe is involved, they will have hallucinations, complex hallucinations. Then again, if PCA is involved, they can have a peduncular hallucinosis. Peduncular hallucinosis means a bright color object. They will have a hallucination of a bright color objects. That is peduncular hallucinosis. Then one more, if bilateral occipital lobe is involved, even they will have ocular apraxia. ocular apraxia. So these are the clinical features what you get in a P2 segment or a peripheral segment. So P2 segment, P1 segment. Simple students, P2 is occipital lobe, temporal lobe. P1 is thalamus, subthalamus, midbrain. Now, let us go to the clinical features of the basilar artery and the vertebral artery. Let me come from below upwards, from the vertebral artery to basilar artery. So, below upwards means first I will consider the medullary syndrome, then pontine syndrome, then midbrain syndrome. Medullary syndrome, lateral medullary, medial medullary, a combination, a total medullary. Pontine, inferior, middle, superior, and in each inferior, middle and superior, medial and lateral. Then you have a midbrain. Above that is a midbrain. Midbrain, medial midbrain, lateral midbrain. First, let me discuss a lateral medullary syndrome, but that case will be kept for you exam if that case is there. What are the anatomical structures which are there in the lateral medulla, students? Lateral medullary syndrome occurs if there is a infarction of the posterior inferior cerebellar artery or a vertebral artery or a superior, middle and inferior medullary arteries. Lateral medullary syndrome will occur. Before understanding the clinical feature of lateral medullary syndrome, we should know what are the anatomical structure present in the lateral part of the medulla. You have a cerebellar, spinocerebellar tract, so they'll have ataxia on the ipsilateral side because spinocerebellar tract is there. So, what are the anatomical structures present in the lateral part of the medulla? You have spinocerebellar tract, so they'll have ipsilateral ataxia. 8th cranial nuclei, vestibular nuclei, so they'll have vertigo, dizziness, nausea. Nucleus ambiguous, 9th and 10th cranial which supplies the muscles of the pharynx, so they'll have nasal regurgitation, hoarseness of voice, dysphagia, especially for liquids, the dysphagia. They'll have hiccups, the cause is unknown usually, why they'll have hiccups. In the lateral part of medulla, sympathetic chain runs, so ipsilateral Horner syndrome. In the lateral part of the medulla, the spinothalamic tract runs, which carries the pain and temperature from the opposite side of the body. So, contralateral pain and temperature will be affected. In the lateral part of the medulla, the 5th nerve nucleus, which carries the pain and temperature from the pons, goes till the C2 cervical spinal cord. So, because the descending nucleus of the 5th nerve, which carries the pain and temperature, ipsilateral part of the face, there will be pain and temperature will be lost. So, ipsilateral face, pain and temperature, contralateral part of the body, pain and temperature. That is lateral medullary syndrome. So, if you know the anatomy, very simple. Then, ipsilateral tractus solitarius nucleus will be there. So, loss of taste sensation, loss of gag reflex because 10th nerve will be affected. Then, very rarely, because nucleus cuneatus and gracilis is affected, they may have the numbness on the ipsilateral part of the body. They may have the numbness. Sometimes the 7th cranial fibers from the nucleus will descend down till the medulla and then ascends up. So, 7th nerve may be affected in some of the cases. But 9th, 10th, 8th, cerebellum, Horner syndrome, pain and temperature contralateral, ipsilateral face, pain and temperature, you should never forget in a lateral medullary syndrome. Then come to the medial medullary syndrome. Medial part, and one more thing, in lateral medullary syndrome, there won't be any motor weakness because corticospinal tract runs medially. They won't have 12th nerve affection because 12th nerve is situated medially. So, now is very easy because medially what are the things situated? You have a corticospinal tract, you have a 12th nerve, and you have a medial lemniscus. So, what are the things you get in a medial medullary syndrome? Ipsilateral 12th nerve affection will be there, contralateral fine touch vibration because of the medial lemniscus will be affected, contralateral motor weakness, corticospinal tract weakness. So, contralateral motor weakness, contralateral fine touch and vibration, ipsilateral 12th nerve. So, in a medial medullary, contralateral fine touch and vibration versus lateral medullary, contralateral pain and temperature because pain and temperature fibers runs in the lateral part always. There is one more syndrome known as a total medullary syndrome, medial and lateral, both combination, medial and lateral medullary, total medullary syndrome. Then you have, if there is occlusion of the basilar artery, what will occur? Two vertebral arteries join together to form a basilar artery. Then you have a pontomedullary syndrome. Basilar artery total occlusion I will explain later. Okay. I want to discuss a pontomedullary syndrome. Pontomedullary syndrome means a combination of a lateral medullary syndrome and a lateral inferior pontine syndrome. I'll tell what is lateral inferior pontine and what are the clinical features. I'll explain, don't get confused. I'll tell you detail. It's a combination of a lateral medullary plus a lateral inferior pontine syndrome is pontomedullary syndrome. And basilar artery occlusion, what will happen? I'll tell later when I come to the pontine syndromes and I'll explain that. So this is the medullary syndrome, lateral medial medullary syndrome. Now let us move up. Two vertebral artery joined together to form a basilar artery. So the basilar artery is the one which supplies the pons, the mainly pons. In the pons, lateral inferior pontine, medial inferior pontine, lateral mid pontine, medial mid pontine, superior lateral pontine, medial superior pontine. So let us come to the clinical features of in the inferior pontine, lateral and medial. So inferior pontine, lateral and medial. Inferior pontine lateral syndrome is also known as anterior inferior cerebellar artery syndrome. Anterior inferior cerebellar artery syndrome. What is the structure present there? Lateral part of the inferior pons. You have a cerebellar peduncles will be there, so they'll have ataxia, ipsilateral ataxia. Eighth nucleus will be there, so they'll have vertigo, nausea. Then there will be a fiber for the conjugate gaze in the inferior lateral pons, so they'll have a conjugate paralysis on the ipsilateral side. You have a seventh nerve nucleus there, so you will have facial nerve affection. And the fifth nerve which runs from the pons will even comes there. So ipsilateral fifth nerve will be affected. Sensation over the face. Ipsilateral seventh nerve, ipsilateral fifth nerve, ipsilateral eighth nerve. Then ipsilateral ataxia. Then ipsilateral conjugate gaze. The one contralateral finding is because spinothalamic tract runs there, contralateral pain and temperature will be affected. That is inferior lateral pontine. Then inferior medial pontine. What are the things affected in the inferior medial pontine? What are the structure? Sixth nerve nucleus will be there. So diplopia ipsilaterally. Sixth nerve nucleus will be there. Diplopia ipsilaterally. Here also cerebellar peduncles will be there. So they will have ipsilateral ataxia. Remember students, whether superior, middle or inferior, lateral or medial, everywhere cerebellar peduncles will be there. So ataxia is a feature in all the syndromes. Generalization. Ataxia is a syndrome in all the features. Medial inferior pontine also vestibular nucleus will be there. So they will have a vertigo, nausea, giddiness. As I told, sixth nerve will be there, so they will have ipsilateral diplopia. Then conjugate gaze also will be affected because conjugate site is there here also, inferior medial pontine. All these are ipsilateral. Contralateral, same like a medial medullary syndrome. Contralateral fine touch and vibration, contralateral motor weakness due to corticospinal tract affection. Simple. Contralateral fine touch and vibration, contralateral motor weakness. Ipsilateral sixth nerve, ipsilateral eighth nerve, ipsilateral conjugate gaze paralysis. This is inferior medial pontine. Now come to the middle pontine. Middle pontine, lateral and medial. First go to the lateral middle pontine. Lateral middle pontine, one cranial nucleus will come here. That is fifth nerve. So they'll have ipsilateral motor weakness, muscles of mastication, and ipsilateral impaired sensation over the face. And as I told, everywhere there will be ataxia, so ipsilateral cerebellar ataxia. What is the contralateral? Pain and temperature. Here also pain and temperature fibers runs in the lateral part of the pons. So contralateral pain and temperature. Coming to the medial pontine, medial mid pontine. Medial mid pontine, as I told, everywhere there will be ataxia, so they will have ipsilateral ataxia. Contralateral, two things. One is corticospinal tract weakness, fine touch and vibration because of the medial lemniscus. That's all, simple. So that contralateral motor weakness, contralateral fine and touch, everywhere same. One thing which you have to remember in a mid-pontine syndrome, lateral mid-pontine is fifth nerve will be there. So muscles of mastication, impaired sensation over the face. Now let's come to the superior pontine. Superior pontine, two things. Lateral superior pontine, medial superior pontine. Lateral superior pontine is also known as syndrome of superior cerebellar artery. As I told, superior cerebellar artery and anterior inferior cerebral artery or nothing but a long circumferential branches of the basilar artery. So now, superior pontine, lateral part. What are the things you get ipsilaterally? What are the things you get contralaterally? Superior pontine laterally, you have a sympathetic chain. So, ipsilateral Horner syndrome will be there. Then everywhere ataxia you get. Here also you will get ipsilateral cerebellar ataxia. Lateral superior pontine, again vestibular nucleus will come. So, ipsilateral vertigo, nausea, vomiting will be there. And lateral superior pontine conjugate gaze also will be paralyzed. So, wherever there are vestibular affection students, even conjugate gaze paralysis also is occurring. So, where all you got the vestibular affection? You got vestibular affection in the lateral inferior pontine you got, medial inferior pontine you got vestibular affection, and lateral superior pontine you got a vestibular affection. In the same regions, you will also have the conjugate gaze paralysis. So, ipsilateral cerebellar ataxia, ipsilateral eighth nerve affection, ipsilateral conjugate gaze paralysis, ipsilateral Horner syndrome in the lateral superior pontine syndrome. Which is the contralateral you get in lateral superior pontine? Pain and temperature, because the lateral part of this pons, medulla, pain and temperature fibers will be located. So, contralateral pain and temperature. Coming to the medial superior pontine syndrome. Medial superior pontine syndrome, here you have to remember MLF will come. Remember M. The medial superior pontine, MLF will come. So, they will have internuclear ophthalmoplegia, ipsilateral internuclear ophthalmoplegia. Then they will have myoclonus. Myoclonus, MLF, medial superior pontine. Remember MMM. The palatal myoclonus is due to the three nucleus. One is inferior nucleus, dentate nucleus, nucleus of tegmentum. Palatal myoclonus. So, they will have ipsilateral internuclear ophthalmoplegia, ipsilateral palatal myoclonus, and ipsilateral cerebellar ataxia everywhere, as I told. Here also will be the ipsilateral cerebellar ataxia. And contralateral, what you get in a superior medial pontine syndrome, the fine touch and vibration because the medial lemniscus. Then contralateral motor weakness due to corticospinal tract involvement. So, some generalization now I want to make of all the syndromes. In a medial, everywhere medial, contralateral you get a corticospinal tract, contralateral you get a fine touch and vibration due to corticospinal tract and medial lemniscus. Lateral, everywhere you get a contralateral pain and temperature. Whether superior, middle or inferior, everywhere you get a cerebellar ataxia. In a middle pontine syndrome, you get a fifth nerve affection in the lateral middle pontine syndrome, because fifth nerve lies there nucleus. Vestibular nucleus, you got affection in three things. One is a medial and lateral inferior pontine and a lateral superior pontine. In the same regions, you got the conjugate gaze weakness also. And in the inferior lateral pontine, you get three nucleus. One is seventh, descending tract of the fifth and eighth. That's all. If you read 4-5 times, know the anatomy, looks complicated, but if you simplify and read 4-5 times, it will be simple, students. This is the pontine syndrome. Now, next is the midbrain syndrome. Midbrain, medial and lateral. Medial is ipsilateral third nerve, contralateral corticospinal tract weakness, that is a Weber syndrome. Ipsilateral third nerve, contralateral cerebral peduncle will be affected. Cerebral peduncle which carries a corticospinal tract involvement. Whereas a lateral midbrain syndrome will be ipsilateral third nerve, contralateral ataxia due to dentado-thalamic tract. That is a midbrain syndrome due to the PCI infarction, the central territory of the PCI infarction. These are the midbrains, the posterior circulation, stroke syndromes. They will keep you if there is any PCI infarction with the occipital lobe infarction or a thalamic infarction like this, or a medullary syndrome, lateral medullary syndrome, definitely they will keep for a postgraduate students, and you should know how to examine anatomy, blood supply and interpretation of the findings. And this patient is having atrial fibrillation. So, how do you manage whenever there is atrial fibrillation like this? CHAD VAS score you have to apply. C is congestive heart failure 1 point, H is hypertension 1 point, age more than 75 is 2 points, is 85 years, 2 points, 65 to 74 years is 1 point. Then vascular disease like MI or a peripheral vascular disease is 1 point, female sex is 1 point, and if any stroke is there, then it is, or a TIA if it is a 2 point. If score is 0, you can give aspirin, no oral anticoagulants. If score is 1, either aspirin or a oral anticoagulant. If score is 2, oral anticoagulant is a must. Warfarin is indicated in a valvular and a prosthetic valves, whereas a novel oral anticoagulants can be given in non-valvular AF. No lower anticoagulants you cannot give in a wall array for a prosthetic valve. Then just a few points about thrombolysis I want to tell. So this is about the anticoagulation in atrial fibrillation. So just I want to tell few points about thrombolysis. Students, whenever a patient like this ischemic stroke comes within less than 4.5 hours, you have to thrombolyze it. So what are the indication to thrombolyze? Age more than 18 years, consent given by a surrogate, and then CT scan not showing any hemorrhage or edema not more than 1/3 of the territory. And if the patient comes within less than 4.5 hours, in Europe, US is 3 hours. Okay, so generally it is taken now as a less than 4.5 hours, you have to thrombolyze it with the TPA. What are the contraindication to thrombolysis? If there is any aortic dissection, intracranial hemorrhage, a previous history, any previous surgery within last 2 weeks, or internal bleeding within last 21 days, RBC less than 50, more than 400, rapidly improving symptoms, a minor stroke, a coma, recent MI, or patient on anticoagulant for the last 48 hours, bleeding diathesis, pregnancy, BP more than 185 by 110, platelet less than 1 lakh. These are all the contraindications for a thrombolysis. You will give TPA. TPA is given 0.9 milligram per kg body weight. A 10% is given initially bolus. The rest is given over 1 hour. When you give TPA, have a 2 IV cannula, no arterial line or a central line, no catheterization for the 2 hours, and no anticoagulation for the 24 hours. And if any deterioration in the mental status, you have to immediately stop it, do a imaging, then give a cryoprecipitate. This is the indications, contraindications, and how you thrombolyze an ischemic patients like this if it comes within less than 4.5 hours. Then the other anti-edema measures, antiplatelet, other drugs, other management, similar like a hemiplegia which I discussed. Everything I discussed in the hemiplegia, you can go through that video. I discussed about the lacunar stroke in that and TIS, you can go through that. This case was mainly presented because a lateral medullary syndrome will be kept for your exam, and even a PCI infarction with the occipital lobe or a thalamic infarction can be kept for your exam. That's why this case was discussed. Just few points about the etiology of the hemorrhagic stroke. The commonest cause of hemorrhagic strokes are hypertension, is the commonest cause of hemorrhagic stroke. That is the commonest cause. And amyloid angiopathy in old age people, amyloid angiopathy. Drugs like thrombolytics, anticoagulants can produce a hemorrhage. Bleeding diathesis, the coagulation disorders like hemophilia, ITP can produce a hemorrhage. Cavernous angioma, AV malformations, capillary telangiectasias can produce a hemorrhage. Or a secondaries from a lung renal cell carcinoma can bleed in the brain, producing a hemorrhage. Or a big ischemic infarction can transform into a hemorrhagic stroke. These are some of the cause of hemorrhagic stroke. Hemorrhagic stroke, the management, other things I have discussed in the hemiplegia. You can go through that video. Okay, students. So this case was discussed mainly to discuss a lateral medullary syndrome and thalamic infarction.
Hello students, we discussed detail about the thalamic stroke. So I had to discuss a few points about the posterior circulation, about the Pontine syndromes, the medullary syndromes, lateral medullary syndrome, medial medullary syndrome, the midbrain syndromes, and the blood circulation of the posterior circulation blood supply. Okay students, right. So here is the blood circulation of the posterior part of the brain. Okay. So here you can see two vertebral arteries joined together to form basilar artery. This is a basilar artery. Okay. So the vertebral artery is giving posterior inferior cerebellar artery. Posterior inferior cerebellar artery. This is a posterior inferior cerebellar artery given by a vertebral artery. Okay. The basilar artery is the one which gives the pontine branches, the deep branches of the basilar artery, which gives the pontine branches. And the basilar artery also you can see gives anterior inferior cerebellar artery, anterior inferior cerebellar artery. And this basilar artery will divide into posterior cerebral artery, two branches, posterior cerebral artery. Okay, and also the basilar artery also gives superior cerebellar artery. So superior cerebellar artery and anterior inferior cerebellar arteries are from the basilar artery. The posterior inferior cerebellar artery is from the vertebral artery. So this is in brief about the circulation of the brainstem. Now, this is how the thalamic infarction looks. Okay, you can make out here the thalamic infarction. Okay, the next one which I'll show, nicely showing the thalamic infarction. You can make out here the thalamic infarction, the hyperdense area which is same like the bone. Okay, right. Okay, so this is now I'll discuss about first the medullary syndromes, the lateral and medial medullary syndrome. Very important, students. Lateral medullary syndrome is a main case. If it is there, they'll keep for the PG exam. It is a PG case, so you should know about that, the lateral medullary syndrome. Okay, students, right? So first you should know the anatomy. What are the structures present in the lateral part of the medulla? If you know what are the structures present in the lateral part of the medulla, then it is easy to understand the clinical features. So here you can see, students, there is spinothalamic tract. The only contralateral sign in a lateral medullary syndrome is the spinothalamic tract sign, that is pain and temperature affection. So contralateral part of the body, there will be a loss of pain and temperature. The rest, all the signs are ipsilateral. You remember this. In a lateral medullary, suppose if right lateral medulla is affected, left side of the body pain and temperature will be affected because the fibers will cross within the spinal cord there only and then it ascends to the medulla. So that is spinothalamic tract. So next you can see here spinocerebellar tract. Because of the spinocerebellar tract, patient will have ataxia. Ipsilateral ataxia will be there. Okay, students, right? So here you can see nucleus ambiguous, which is a nucleus of the 9th and 10th of the glossopharyngeal and the 10th nerve, the vagus, which supplies the muscles of the pharynx. So because muscles of the pharynx are affected, patient will have dysphagia, especially for liquids, and also he will have hoarseness of voice. So these are all ipsilateral signs. The dysphagia, the hoarseness of voice, these are all ipsilateral signs. Then here you can see nucleus of the tractus solitarius, which is of the 7th nerve, the posterior 1/3, the anterior 1/3 of the tongue, the 7th nerve, chorda tympani, and posterior 1/3 of the tongue, the glossopharyngeal. Both together will form the tractus solitarius, so they'll have taste affection. And one more here you can see descending tract of the 5th nucleus. Descending tract of the 5th nucleus. So ipsilateral side of the face, they'll have loss of affection of the pain and temperature. Okay, this nucleus go till C2, student, spinal cord, C2 it goes. So ipsilateral face, pain and temperature. Contralateral body, pain and temperature will be affected. Okay, student, in lateral medullary syndrome. The one more important structure in lateral medullary syndrome is sympathetic chain. Here you can see sympathetic chain. So ipsilateral sympathetic Horner syndrome will be there because the sympathetic chain is affected. So ipsilateral Horner syndrome, ipsilateral face pain and temperature, ipsilateral dysphagia, hoarseness of voice. Then they'll have hiccups also. Hiccups will be there. Then ipsilateral taste sensation affection because of tractus solitarius. Ipsilateral ataxia because of spinocerebellar tract. The only contralateral, as I told, is spinothalamic pain and temperature will be affected. It is also known as Wallenberg syndrome, Pica syndrome, posterior inferior cerebellar artery syndrome. It is produced by mainly 5 arteries branch occlusion, students. Mainly common is vertebral artery. Then posterior inferior cerebellar artery also can produce lateral medullary syndrome or superior middle and inferior cerebellar arteries. Okay, student. These are the few points about lateral medullary. You should know about medial medullary also. So in this lateral medullary, you can make out, students, corticospinal tract is not affected. So motor weakness won't be there and plantar will be flexor in lateral medullary. Whereas in medial medullary, you will have the, because the corticospinal tract is affected, contralateral part of the body, they will have the motor weakness. Because the medial lemniscus, this is nothing but the dorsal column which carries the fine touch and vibration. So they'll have contralateral part of the body, fine touch and vibration will be affected. Ipsilateral 12th nerve, so glossopharyngeal nerve will be affected. Ipsilateral 12th nerve glossopharyngeal, sorry, not glossopharyngeal, hypoglossal nerve will be affected. So ipsilateral hypoglossal nerve, contralateral motor weakness, contralateral fine touch and vibration. This is a medial medullary syndrome, also known as Dejerin syndrome. Dejerin syndrome. So in a medial medullary, contralateral fine touch and vibration, contralateral. Motor weakness, ipsilateral 12th nerve. Okay, student, this is medial medullary and lateral medullary syndromes. So very important, you should know from a postgraduate point of view. Next important thing is the Pontine syndrome, students. So in a Pontine syndrome, students, so mainly there are, you have superior pontine, middle pontine and inferior pontine, divided into three: superior pontine, middle pontine, inferior pontine, and each is again divided into lateral and medial. So then you have lateral superior pontine, medial superior pontine, middle lateral pontine, middle medial pontine, inferior medial pontine, inferior lateral pontine. So there are some generalization in these Pontine syndromes to understand that you should know before going into the Pontine syndromes. Little complicated, but if you know the anatomy and some generalization, if you make out, it will be easy. See, students, in all the medial, okay, superior, middle and inferior medial, as I told, the contralateral, the fine touch and vibration because the medial lemniscus, contralateral corticospinal tract affection. So contralateral motor weakness will be there in all the medial. So that you should know in all the medial. Okay, students, that is one important thing. In all the lateral, pain and temperature, spinothalamic tract will be affected. Okay, that is one more important lateralization. In all the Pontine syndromes, in all the six, superior, middle and inferior, whether medial or lateral, ataxia will be there because of the cerebellar peduncles, which will be attached to the pons. Everywhere ataxia will be there. Okay. Then in inferior lateral, okay, in inferior lateral, inferior medial, okay, and superior lateral, eighth nerve nucleus will be affected, students. Okay, student. So inferior medial, inferior lateral, superior lateral, the eighth nerve will be affected. These are some generalizations, students. Okay, students, right. So now let us come on the this inferior. In the inferior, medial and lateral will come first. No, in the inferior, medial and lateral will come. Okay. So as I told, both in a medial and inferior lateral, eighth nerve will be affected. Eighth nerve will be affected. Then in a medial inferior syndrome, so the generalization, as I told, contralateral fine touch and vibration, contralateral corticospinal tract will be affected. See here, corticospinal tract will be affected. Okay, that will be affected. So here in the lateral inferior, two cranial nerves will come, students, along with the eighth nerve, which is common in medial and lateral inferior pontine, seventh nerve and fifth nerve. Okay, seventh nerve and fifth nerve you should know. Okay, fifth nerve, the descending nucleus of the fifth nerve will come till C2. Okay, so here it is situated laterally, lateral inferior pontine. So they will have ipsilateral phase, pain and temperature will be affected. Seventh nerve will be affected, ipsilateral. Seventh nerve will be affected. And as I told, lateral spinothalamic tract will be situated. So contralateral pain and temperature will be affected. Okay, students. So this is about medial and lateral inferior pontine syndrome. So next is mid-pontine, students. Mid-pontine, okay. And one more point I want to tell in the inferior medial, one pure motor cranial nerve, sixth nerve will come, student. Sixth nerve nucleus will come here. Okay, so they have the abduction problem in the inferior medial pontine syndrome. Sixth nerve will come. Okay, so for cranial nerves also you can make some generalization. Usually the motor cranial nerves like third, fourth and sixth will be medial problem. Whereas the fifth nerve is a mixed, both sensory and motor. Seventh nerve you have both motor and sensory. They'll be situated laterally. Okay, so that's why here you are having a fifth nerve and the seventh nerve laterally situated in the inferior lateral. Okay. So inferior medial, sixth nerve will be affected. So let us go on to the mid-pontine. In the mid-pontine, in the medial mid-pontine, nothing special. Same contralateral fine touch and vibration. Contralateral corticospinal tract will be affected. But in the mid-pontine, lateral, one cranial nerve, fifth nerve. Fifth nerve here, the motor nucleus will be affected. So the muscles of mastication will be affected. Okay. And the principal sensory nucleus of fifth nerve, which carries a fine touch and vibration, but not the descending. Descending will carry the pain and temperature. That won't be affected here. Only the principal sensory nucleus. So here you can see sensory nucleus, fifth nerve, motor nucleus will be affected. And as I told, everywhere ataxia will be there because the cerebellar pedental will be there. And lateral, as I told, spinothalamic tract is a common in the lateral pontine syndrome. So lateral mid-pontine spinothalamic tract will be affected. Okay, students. So very simple here, no problem. So let us move on to the medial and lateral superior pontine. First, we'll come to the medial. In the medial, you remember like all MM students. Okay, so MLF will be affected, so they'll have an internuclear ophthalmoplegia. Myoclonus, because palatal myoclonus, because of inferior olivary nucleus will be affected. MLF will be affected, and as you know, medial lemniscus is nothing but dorsal column. So contralateral fine touch and vibration, contralateral corticospinal tract will be affected. That's it. So in a lateral superior pontine students, you will have Horner syndrome because the sympathetic chain will be going, and PPRF will be there, parapontine reticular formation. So they'll have a gaze palsy will be there. And as I told in the generalization, in a lateral superior pontine, eighth nerve will be there. Eighth nerve is there in a lateral superior pontine, inferior and lateral. The pontine inferior, medial, inferior, lateral pontine syndromes. Inferior, medial, inferior, lateral, superior lateral pontine syndrome, eighth nerve will be affected. As I told, similarly in the lateral generalization, lateral superior pontine, contralateral spinothalamic tract will be affected. I'll always here spinothalamic tract will be affected. Okay, students, right? So the superior lateral pontine is also known as superior cerebellar artery syndrome. Similarly, the inferior lateral pontine is known as anterior inferior cerebellar artery syndrome. Okay, that is ICA. You know PICA, no? PICA, I discussed the lateral medullary, posterior inferior cerebral artery syndrome, PICA syndrome. So, inferior lateral pontine is known as anterior inferior cerebellar artery or ICA syndrome. Superior lateral pontine syndrome is known as superior cerebellar artery syndrome. So, let us go on to the midbrain syndrome, student. So, midbrain, very important nucleus is the third nerve nucleus. So, you should know about third nerve nucleus. So, ipsilateral third nerve, contralateral hemiplegia will be there. That is known as a Weber syndrome. Weber syndrome. Ipsilateral third nerve, similarly with the contralateral ataxia because of the dentatorubral tract fibers, is known as a Claudius syndrome. A combination of this Claudius syndrome and Weber syndrome is a Benedict syndrome, students. So, this is a midbrain syndrome. So, midbrain only two: Claudius syndrome, Weber syndrome. Weber's is ipsilateral third nerve, contralateral hemiplegia. Claudius is ipsilateral third nerve, contralateral ataxia because of rubrodental fibers. Combination is Benedict. Two midbrain syndromes, two medullary syndromes: lateral medullary syndrome, medial medullary syndromes. Pontine syndromes are six: superior, middle, and inferior. Again divided into medial and lateral, students. So thank you. All these diagrams are taken from the Harrison. I acknowledge the Harrison textbook of medicine for these students.